Good morning, all. I'm going to give you a presentation on a number of different things that are initiatives that we have in AOA and some of the newer things that are happening in our world. But first, this is where I work. San Francisco is not rural, and I won't even venture to think any differently. But this is where I live. I live in rural Central California. One senior center, transportation is a senior bus. There's no town bus service. There's no home health, a few doctors. We have one dentist, no specialists. The hospital or clinic is an hour and a half away. And case management is usually the Meals on Wheels driver. As one of my good friends in aging used to talk about it, out here we have an abundance of scarcity. So why is rural health and rural outreach important? Briefly, there are 59 million people who live in rural America. That's more than 1/5 of the U.S. population. 75% of all the nation's counties are rural, representing 83% of the total land mass in the United States. 38% of rural residents live in areas with no public transportation. And 1.6 million rural households don't even have access to a car. There are limited resources in workforce, which make doing more with less kind of the operation of the day. And the Medicare population is increasing by 10,000 persons a day. As this population increases, chronic diseases will increase, calling for the need for more health prevention and services at the community level. Nationally, to date, we are seeing trends that place more emphasis on medical social models of weaving health and human services to address some of these issues. To be brief, I will only mention 3 of the many areas in which aging are currently involved. The Patients Protection and Affordable Care Act, or ACA as we call it, the White House Rural Council, and the newly established Administration for Community Living. The ACA, within the ACA, there are several areas that address community, aging, and consumer choice. And quite a few codicils that you could look up in there that deal with rural itself. The first one that I would take a look at, though, is the Money Follows the Person. This is a CMS Medicare initiative providing consumer choice by giving consumers the opportunity of purchasing services that will keep them independent in their community. 2 other examples providing consumer-directed choices are the Aging and Disability Resource Centers and the newly let out grant programs of community care transition programs, which I'll talk a little bit more in detail later in the presentation. The White House Rural Council was established in December of 2011, so it's brand new. This council will coordinate President Obama's efforts in rural America by performing 3 core functions. It will streamline and improve the effectiveness of federal programs serving rural areas, engage stakeholders on issues and solutions in rural communities, and promote and coordinate private sector partnerships. In HHS, the representative to this council is the Office of Rural Health Policy's Tom Morris. The Administration for Community Living, it's hard for me to say that right yet. It's because this was established earlier this month. And this is the newly developed agency that is my new home. The agency holds beneath its umbrella the Administration of Aging, the Office of Disability, and the Office of Intellectual and Developmental Disabilities. This agency is the natural progression for aging and disability communities and supports and provides new opportunities for the aged and the disabled, their families, and caregivers. What this all boils down to is a system of long-term services and supports that provide better quality, care, and cost, something that strikes a very familiar theme with most people at this point in time working in health and human services. This is a diagram that shows the newly developed Administration of Community Living. I provide this not only for an illustrative purposes, but to specifically point out the 10 regional support centers in the middle, in here. These centers cover the 10 HHS regions and serve as focal points for the aging network and liaisons for the states we serve. You can learn more about AOA's regional support centers by going to the AOA.gov website at www.aoa.gov. This is the Aging Network. Based on the Administration on Aging, state units on aging, area agencies on aging, 256 tribal organizations, this national network of state and local stakeholders, public and private, provide millions of meals, personal care, case management, and respite care to seniors, caregivers, and their families. The network, especially the area agencies at the local level, can be your new best friends in developing community partnerships. Through our network, AOA programs and initiatives address our efforts for outreach at rural areas and provide tools for the toolbox, for your toolbox, to health and human service agencies in the community. However, it is important to preface this discussion that even though the network casts a wide footprint on rural America, it should be understood that many, but not all, services are available in rural areas. This is a list of some of the home and community-based and health prevention services provided by the Administration on Aging. We start with 6 core services funded under the Older Americans Act that are most familiar to people. One of those is supportive services, which is a home and community-based services that link senior center activities, fund transportation to some extent, case management, and other supportive services to our nutrition sites. Nutrition services are also funded under the Older Americans Act, and most people would know this by either the congregate nutrition centers or our Meals on Wheels programs. We also fund disease prevention and health promotion services, caregiver services that provide information, support, counseling, and respite care for caregivers, and nutrition and caregiving services to 256 Native American, Native Hawaiians, and Native Alaskan tribes. We also fund vulnerable elder rights activities such as the Nursing Home Ombudsman, legal services, and Senior Medicare Patrol programs. These core programs meet the mission of ACL in helping people maintain the health and independence in their homes within their communities. Now let's talk about a few of the initiatives. Aging and Disability Resources, or ADRC. Why do we have them? Well, because of fragmented systems of information and referral, multiple access points, services, and agencies, eligibility criteria, and funding sources, navigating this system is difficult. The number of long-term service support options has increased dramatically over the last 2 decades, which gives more choice but also gives more confusion. A professional friend or a family member may refer an individual to one known service. Consumers then may never know what other options are available. ADRCs build consumer trust through objectivity and by enhancing individual choice through options counseling, supporting information and decision-making, and streamlining the access process. New to us in 2010 were the Community Care Transitions programs. They were established out of the ACA, Section 2036, as I said, within the last 2 years. Transitional care is defined as a set of actions designed to ensure the coordination and continuity of health care as patients transfer between locations at different levels of care within the same location. In many parts of the United States, this program joins together a partnership of community health centers with local nonprofit organizations, in many cases the local area agencies on aging, to reduce hospital readmissions and provide transitional care between community institutions and home. New to us is in consumer direction is our new Veterans-Directed Home and Community-Based Service Program. What is VDHCBS? It's a program grounded in the evidence that based on cash on counseling, or the money follows the person model that we talked about a little earlier. It's a program that provides veterans of all ages with consumer-directed home and community-based service options and empowers veterans to direct their own services and support. It also supports families and family caregivers of veterans, and it helps veterans stay in their homes and be engaged in their communities. To date, 23 states are working with 31 veterans medical centers and 91 area agencies on aging and aging disability resource centers to link 673 veterans who are being served currently or have been served. AOA also deploys a broad range of national distribution of health promotion and disease prevention programs, from local health fairs to sponsorship of chronic disease health management and falls prevention programs, to support of people with Alzheimer's disease, caregivers, and their families. At AOA, elder abuse has always been on our radar for quite some time, and advocates have been trying for years to pass the Elder Justice Act. They were successful in March 23rd of 2010, and although not funded to date, this act sets a placeholder for a range of programs and services and brings important federal leadership, coordination, and resources to a growing problem of elder abuse, neglect, and exploitation. AOA also has additional support by funding a number of resource centers designed to provide information to consumers and technical assistance to professionals on a variety of topic areas. As you can see within the classification of information for professionals, the resource centers include a broad range of categories by area of emphasis to make a list simpler to navigate. For more information on our resource centers, you can go to the AOA.gov website. In carrying out the services I've discussed, AOA works with a large array of partners through HHS and local rural communities. This list is not exhaustive, but names some of the many great organizations we partner with to bring structure to this diverse network. A linchpin of all the AOA services are our state units on aging, as I talked about in the regional centers, and at the local level, the area agency on aging. As you can see, the area agencies on aging are everywhere, with a majority of them either in a mix of rural and urban or rural areas. I like to talk about area agencies as the best kept secret. You may know them as departments of aging, councils of government, or the AAA, not to be confused with the car service. But they may be in a county government, in a private nonprofit, or a regional center, but they're out there. Bottom line, they are our boots on the ground, and they are, for you, a valuable resource. It's all about the network. We are fast entering an age of promoting the connection of health and human services. Each group brings to this collaboration its own uniqueness, language, and culture. To better serve our communities, we will need all the tools we can get. And as I stated before, some services may not be offered in all the rural areas, but we continue to endeavor to provide the access to them. In conclusion, if I were to leave you with one thought, I'd like it to be that you have new tools that are now arm you with information that there is a network out there, and they are dedicated individuals who are eager to partner with you. If I leave you with one request, that would be to call them, get in touch with them, contact them, make a connection. Thank you.
Thank you, Dennis, for setting that up so nicely. Dennis talked a lot about the network, and I'm going to draw on what he has been talking about to go into some more of the resources that can be accessed through that network and some outreach strategies to reach rural seniors. So I'm going to go into a little bit more of a snapshot of some of these rural and isolated seniors. I want to focus also on the relationship between health and economic security for seniors, because those are so intertwined for this population, before I launch into some of these resources and solutions. So, Dennis talked about the fact that 20% of the people who live in rural areas are seniors. And we know that, according to the most recent census, that about 14% of people on Medicare or over age 65 do live in rural areas. But one of the really interesting things that NCOA likes to drill down is to look not only just at people in rural areas, but the people that we talk about as being geographically isolated. And we make a distinction between just rural residents and the geographically isolated, because the ones who are isolated are those who live alone. They don't live with a sort of network of family, and they live in communities with less than 20 people per square mile. So we're talking about the really extremely rural, living alone, may not know anything about this network and the resources out there. And there's over 500,000 of these seniors that are geographically isolated. And we know that they have a higher rate of poverty than just seniors in general. Approximately 20% have incomes below the poverty level, so below $11,000 a year. Now, what does that mean? Now, obviously, Dennis kind of identified some of the barriers that are facing rural seniors related to transportation and access to services, but we also know that isolated seniors are more likely to skip meals because they don't necessarily have access to a grocery store, or, you know, Meals on Wheels might not particularly, you know, service their area, or they might not know about that. We know that they are less likely to receive public benefits that they qualify for, that can help them pay for some of those food and prescriptions and home energy assistance. They're also more likely to keep their homes at unsafe temperatures, which can have an adverse effect on their health. And we know that many of them have a higher number of chronic conditions. And that brings me to I want to talk about the relationship between health and economic security, because we really know that for people who have very little in income and resources, they're far more likely to suffer from chronic conditions. As you'll see on this slide, we know that of the 56 million people who are over age 60 in this country, 21.8 million have incomes below 250% of the federal poverty level. That's about $27,000 a year. Now, I know that if you live in a rural area, $27,000 a year may be quite a bit of money. But we've really identified this as being kind of the threshold, because it's usually when people are one event away from economic catastrophe, a foreclosure or a job loss or a medical crisis, and they're really sort of plunged into that poverty level. Now, 18.8 million of these people have one or more chronic conditions, and 14.5 have more than 2 chronic conditions. NCOA did a survey in 2009 about people with limited incomes and chronic conditions, and one of the things that the survey found was that 38% of those with a chronic condition did not have the money to do things that would improve their health. And if we look at this next visual, what you'll see is the most common chronic conditions amongst this population, hypertension, arthritis, diabetes, are conditions that really have a significant sort of economic impact. They're expensive, they require medications. If left untreated, they have significant cost ramifications as far as like hospitalization and surgeries are concerned. So what can you do to connect people with some resources? Well, Dennis mentioned one of these already, the chronic disease self-management programs. These are for people who have chronic conditions, and they're really about empowering them to manage those conditions and to deal with those difficult symptoms. They are evidence-based, developed by Stanford University, and I'm happy to say that in addition to being offered in the community through like senior centers and area agencies on aging, NCOA recently received a license to be able to offer it online. So for people who live in rural areas who may have fairly decent internet access, they are able to sign up for these for free and to participate in these programs. They're about 6 weeks long. You see the sign up there, www.restartliving.org. That website will also help people find community workshops if they prefer to do in person as well. Another resource that I really want to point out, and this is particularly useful for people who may not have internet access, who may feel far more comfortable trying to connect with somebody over the phone. This is the Eldercare Locator, and this is funded through the Administration on Aging. It's administered through the National Association of Area Agencies on Aging, and it's a toll-free number that people can call Monday through Friday, and they can get connected through what we call warm transfers, meaning that even though they're calling a 1-800 number with somebody sitting in Washington, that person in Washington will get on the phone with somebody in rural Montana, for example, and connect them via the phone, via like three-way call, to a person at an area agency on aging, an aging and disability resource center, any one of those community resources that Dennis mentioned. And they can get help with finding financial assistance, figuring out how to apply for benefits, if they need help with health services or home repair or weatherization options, finding out about transportation, legal assistance, a wide variety of services. And this is just a really wonderful resource and completely free. All you need to have is a telephone number, a telephone. Another really wonderful resource out there are the state health insurance assistance programs, which are called CHIPS. These are federally funded, but they are administered in each state and are required to provide free and objective counseling on Medicare and other related benefits to people who have Medicare. And they're also charged with helping people who have limited incomes to apply for specific benefits that help make Medicare affordable, such as the Part D prescription drug low-income subsidy and the Medicare savings programs, which can help people pay their Medicare premiums. SHIPs are also charged with educating seniors about preventive benefits. There are a wide range of preventive benefits that are now free as a result of the Affordable Care Act, and the SHIPs are charged especially with going into rural areas and to talking to people about those and making sure that they use them because they're there for them. All states have their own toll-free number, and many of them have local offices, including in the rural areas. So if you want to get the details for your state SHIP, we encourage you to go to Medicare.gov and look it up for your state. But they're a wonderful resource. I want to point out a couple online resources as well that are administered through the National Council on Aging. Now, I know that I said before that rural seniors don't necessarily always have online access. So some of these, they may be useful depending on where you live, but they can also be accessed pretty much anywhere. So if a person, if you're working with patients or clients who are coming into your healthcare facility or a clinic, you can also sort of use these tools there. NCOA has administered Benefits Checkup for over 10 years now, and this is a web-based tool that screens for over 2,000 public and private benefits. So everything from food assistance to prescription assistance to respite care to state tax relief programs. And anyone can use it. You can also use it to help a client, or if you're a caregiver for an elderly parent or a relative, anyone can go on. It will ask you a series of questions about income and health situation, drugs that you're taking, and at the very end of the screening, it comes up with a list of all of the programs that a person is potentially eligible for, as well as in very basic English, kind of what those programs are, as you see here, and how to get information about applying for them, local resources. If there's a local office where somebody can go in to apply for that program, it will tell you that address. It'll give the website for a program. It will also, if the application form is available online, you can download it. If it's available in other languages, you can download it. So this is really a wonderful tool for people to use, especially for those with low incomes who may be eligible to receive lots of assistance. And we've done some data analysis with Benefits Checkup and really found that about 80% of the people who use the tool are missing out on multiple benefits, and really could, if they apply for these benefits, could save millions of dollars, collectively millions of dollars every year. So another tool that NCOA recently launched is our Home Equity Advisor at homeequityadvisor.org. And this is for older homeowners to look at and determine how to use and protect the value in their home. And so we're not selling any products. I want to make that perfectly clear. This is really a kind of financial education tool. I don't know if you can see very well that screenshot, but under the tab that says My Situation, people can look up for information for example, if they have a disability and they're looking at home repair or modification because of that disability, or if they're potentially interested in a reverse mortgage, they want to check and see if that might be an option, or facing, unfortunately, foreclosure or bankruptcy, or trying to find cash for health or other expenses. There's a little quick check on this site that they can just fill in some information about kind of what their situation is and get the advice and learn where to go to for more information. And as of yesterday, we've actually just launched this site in Spanish as well. So if you go onto the site, you'll be able to see the Spanish link for it. Another tool that NCOA provides, we have funded 22 benefits enrollment centers across the states. Now, some of them are in urban areas, but as you'll see from the map here, some of them are actually working statewide in particularly rural states, for example, in West Virginia, in Maine, in Montana. And what these benefits enrollment centers are charged with doing is being a one-stop shop for people to access all of the benefits that they're potentially eligible for. So it's not just Medicare, it's not just Medicaid. They have community networks with their Medicaid agency, with their Social Security office, with their food stamp office, with all of those sort of administering agencies for benefits. And the person can go into or call the Benefits Enrollment Center and really get a comprehensive screening and assistance and follow-up to try and access those benefits. We're really hoping to be able to expand this into more geographic areas. You'll see at the very end of this presentation the link to NCOA's site. You can look up and see if there's a Benefits Enrollment Center in your area and find the contact information. So I do want to just emphasize a few really interesting and creative ways that we have heard from not only our benefits enrollment centers, but from the Aging Network regarding how to reach rural seniors and how they've been effective. So let me just highlight some promising practices that we've heard from the field. In Manchester Township, New Jersey, the township has a significant senior population, and they have a commitment to helping the vulnerable seniors in that population to access benefits and services. And so what they did is the kind of local area agency on aging partnered with the 911 system, so like the police 911 kind of call center. And they developed this system of reverse 911 calls. So they identified households in this township that had seniors, and they used the kind of 911 system to make calls from 911 to the households to invite them to these special breakfasts that were being held at like community centers as part of health fairs, and to really tell them, you know, you need to come to this. We're going to be helping people get farmers market vouchers. We're going to be helping people apply for food stamps. It was an incredible success and a really excellent example of how the Aging Network and the kind of health clinic and the police force actually kind of partnered to reach this population. Many of you have probably been involved in outstationing of workers at community sites. We hear about this a lot, and we know that this continues to be a very successful practice. A lot of area agencies on aging or senior centers or anybody who's doing kind of health or benefits access work will connect with community groups, churches, for example, faith-based organizations, cultural groups, particularly if you're looking at an area with a high percentage of seniors who may come from a different culture. For example, in the Pacific Northwest, there's a lot of rural Korean and Asian seniors. But being able to outstation someone at the site, like maybe it's once a week, maybe it's once a month, but helping answer questions, make referrals, do screenings for benefits, that's always been quite a successful tool for reaching those sort of rural seniors, getting them basically at an area or a location where they already have trust in that community site. In Maine, the Area Agency on Aging and the Elder Law Services decided to use benefits checkup in a really creative way. They purchased these computers and printers and a little kind of mobile rolling cart, and they set up these mobile benefits kiosks. And they partnered with, for example, Goodwill stores, community centers, churches, and driving around rural Maine and setting up these stations in libraries and all these places. They would have a volunteer, and they would sit down with the seniors in these areas and help them to complete a benefits checkup screening, and then follow up with them. They would provide sort of a phone number and that sort of thing where the person could follow up as far as applying for the benefits. But they had tremendous success with that. Again, reaching people where they are and not having to obviously rely on transportation and that sort of thing. And something similar in Connecticut, the SHIP program purchased an RV thanks to a state pharmaceutical assistance grant. And it was a wheelchair accessible vehicle, which they called the bus. And it's equipped with a satellite dish for internet access. It has 4 computer workstations. It has TV, DVD, VCR, all this kind of technology and brochures. And they drive around rural Connecticut, and they use the Medicare Plan Finder tool to help rural residents to select their prescription drug plans every year. They will do benefits checkup screenings. They will help people access the state Medicaid system online, and really do a lot of outreach and education through this bus. So I know that obviously resources are scarce and not a lot of states can afford to get a bus, but if you do find a sort of partner organization that might be able to, help with a grant for something like that, that's a really wonderful and effective method to reach out to this population. So with that, I want to leave you with my contact information and, again, encourage you to visit ncoa.org. A lot of these promising practices that I just mentioned are available on the Center for Benefits website, which is under ncoa.org if you want to look those up, as well as more information on the benefits enrollment centers. You're welcome to use benefitscheckup.org. Do a test case, use it with somebody you know. And again, the homeequityadvisor.org, if you know patients or clients who are struggling to pay for issues related to their housing, we encourage you to use that site.